A stroke happens when blood flow to a part of the brain is cut off. We often think about the classic signs of a stroke's aftermath: weakness on one side of the body, difficulty speaking, memory loss. These are serious challenges that demand immediate medical attention and long-term rehabilitation. However, there is another, often overlooked consequence: vision loss. This is the silent deficit of vision loss. It is missed by too many patients, families, doctors. This oversight is a significant problem in stroke care. A person recovering from a stroke faces immense hurdles. They might be labeled clumsy, labeled confused, labeled uncooperative. In reality, they may simply be unable to see as they once did. Not seeing the fork on the left side of their plate is not confusion. It could be a visual field cut. This diagnostic gap leads to slower rehabilitation, increased risk of accidents, and profound frustration. The reasons for this oversight are understandable, but not excusable. In acute stroke care, the focus is on life-saving measures: stabilizing the patient, assessing motor function, assessing speech. Vision testing often takes a back seat. To identify these problems, we first need to understand what they look like. Post-stroke vision issues are not about the health of the eyes themselves. The eyes may be perfectly fine. The problem lies in the brain's ability to process the information the eyes are sending. One of the most common conditions is visual field loss, often called hemianopia. This is like a curtain falling over one half of your field of view. A person with this condition might not see someone approaching from that side. They might only read the words on the right half of a page. Another frequent and disorienting problem is double vision, diplopia. It happens when stroke damages the nerves controlling eye movement, misaligning the eyes. They stop working as a synchronized team. The brain then receives two slightly different images and cannot merge them. A survivor might see two overlapping door frames, or two sets of stairs. Confusing and dangerous. It can make walking nearly impossible. Reaching for objects becomes unsafe. Judging distances fails. It can also cause severe nausea and headaches. Then there is a more complex, subtle condition: visual neglect, inattention. This is not seeing, it's attending. The brain ignores sensory info from one side of the body and space. The good news is, you don't need to be a neuro-ophthalmologist to spot a vision problem. Families and bedside nurses are on the front lines. They often detect the first clues. Be an observant detective. Watch how the person interacts with their environment. One telling sign is a consistent head turn. If they keep their head tilted or turn to one side when looking straight ahead, they may be trying to bring the affected visual field into view. It's a compensation strategy, signaling the brain is missing information. Watch navigation. Watch mealtime behavior. They will frequently bump into things on one side. They might collide with a door frame. They might not notice people approaching from the blind side. Once a potential vision problem is suspected, the medical team must act. A comprehensive assessment does not have to be complicated or time-consuming, especially in the initial stages. It can begin with simple, low-tech screenings that can be performed right at the patient's bedside. Every stroke patient should undergo these basic checks as a standard part of their initial evaluation, just like checking their blood pressure or motor strength. The first and most critical test is a confrontation visual field test, which can be done in under a minute by a doctor or nurse. In this test, the healthcare provider sits directly in front of the patient and asks them to cover one eye and look straight at the provider's nose. The provider then holds up a certain number of fingers in the upper right, upper left, and lower left, and asks the patient to identify the number. If the patient consistently fails to see the fingers on one side, it is a strong indication of a visual field loss. This simple screen can quickly catch major deficits like hemianopia. Okay, the next step is to check for eye movement problems that cause double vision. The provider can ask the patient to follow their finger up, down, left, right, and diagonally. The provider watches to see if both eyes move together smoothly or if one eye struggles to keep up. They should also directly ask the patient, "Are you seeing one finger or two?" Answering two is a clear sign of diplopia. For visual neglect, a simple cancellation task can be used. A patient with neglect will ignore the targets on one side of the page.